Hey y'all. In the past, I had done a review on a literature review that talked about things that we can utilize post-dry needling to reduce soreness. This was one of the studies that was included in that literature review. Now, at that time, I could not find open access to this article, so I wasn't able to actually read it. But since then, I have been able to find open access. So this is that study, which talks about the immediate and short-term effects of combining dry needling and electrical stimulation on post-dry needling soreness in patients with chronic myofascial neck pain. Initially, the study talks about what a active trigger point versus a latent trigger point is. And for an active trigger point, it has some sort of spontaneous pain. So a spontaneous pain, it means that it hurts without you touching it. Versus a latent trigger point only hurts if you are poking on that trigger point. And then it talks about electrotherapy and how electrotherapy has been used for pain. So this is something like TENS. Also talks about how needling has been shown to have similar alleviating effects on pain when compared to a lidocaine injection. So this is just the history for why they're doing this study. Side effects of needling, though, include soreness. It says it can be anywhere from a few hours to 2 to 3 days. Now, 2 to 3 days is a long time. If your patients are getting sore for 2 to 3 days after needling, you are likely overdosing your patients. But this is a really big deal because if a patient is overly sore from needling, it can lead to patient dissatisfaction, them developing an aversion to the technique, and then a loss of treatment adherence. In that literature review that I was referring to, I believe it said that 51% of patients that receive dry needling do not want to try it again. More than half of patients that get dry needled do not want to try it again because of how sore they are from their treatment. So the amount of soreness that we create in our patients is a really, really big deal because you do not want to lose a patient because needling could be the one thing that would get that patient better. Pardon me for all the sun that's beaming in my eyes right now. So some things that have been able to work for post-dry needling soreness include ischemic compression, so just applying some pressure in that area, spray and stretch, ultrasound, and they also had in that literature review they talked about like eccentric and isometric loading. They talked about KT tape, so there were some other things that they looked at as well. But we know that there are some things that work well for post-dry needling soreness, such as these that they have listed here. So again, ischemic compression, spray and stretch, and ultrasound. But really, loading is the best thing that you guys will find if you look at that study. Furthermore, studies have shown that there's a hypogesic effect with TENS that is applied using an electroacupuncture approach, meaning the electrodes are on the needles themselves. So it's not topical, it's actually attached to the needle. And then the objective of this study was to assess the effectiveness of combining electrical stimulation with dry needling versus just dry needling alone in improving post-dry needling soreness, neck pain, neck disability, pain pressure threshold, and cervical range of motion in patients with myofascial neck pain. Now, in this study, they only did one needle in the upper trap for those that had electrical stimulation because you have to have the lead connected to, there has to be a positive and a negative. The negative was just attached to a topical pad, but only the positive was attached to the actual needle. So in all of this, patients only got one needle. So this is a single blinded randomized control trial. The outcome assessor didn't know what group the subjects were in. So there was obviously the patients knew who got electrical stimulation done. The therapist who did the electrical stimulation knew who got it done. But the one who did the assessment afterward did not know who got needled. So it was single blinded. There were 62 patients with chronic neck pain that were selected to participate in the study. Here's the inclusion and the exclusion criteria for their outcome measures. The primary outcome measure was pain intensity for post-dry needling soreness and neck pain intensity, as well as disability. They used a pain diary that looked at post-dry needling soreness. This was measured at 24 hours, 48 hours, and 72 hours post-needling. The neck pain intensity was measured before needling, and then immediately after needling, and then at 72 hours after needling. And then the degree of disability was registered before needling, and then at 72 hours post-treatment. They also looked at pain pressure threshold and cervical range of motion before dry needling, immediately after, and at 72 hours post-needling. All right, so for the procedure, they used a 0.32 by 40 millimeter needle. And they did this, again, only in the upper trap. Once they removed that needle, they actually added some ischemic compression. So again, ischemic compression has been shown to work where you just apply pressure to the area. So for every group, they removed the needles and they applied ischemic compression for 90 seconds after removing the needles. Subjects in the in the dry needling group with electrical stimulation had dry needling of the upper trap into an active trigger point. They had to get at least 2 twitches, and then immediately afterward they applied this electrical stimulation onto it. The electrical stimulation, again, there was one electrode that was on the needle, so the negative was applied onto the needle. Second electrode was an adhesive one, so they just applied a pad, like a TENS unit. They applied a topical pad onto the skin, so they had somewhere for that lead to be connected to. There was a biphasic current with low frequency at 2 hertz and 120 microseconds, and this was applied for 15 minutes. All right, this just talks about how they did the interventions, randomized, and then the groups that they were in, and then how they lost some of the patients that were in the follow-ups. All right, for primary outcomes. So first, we're looking at the visual analog scale for post-dry needling soreness. The group that had electrical stimulation done showed a greater improvement in post-dry needling soreness at all follow-up periods. So that was at 24, 48, 72 hours post-needling. All right, visual analog scale for neck pain intensity. Immediately post-treatment, there were differences, which showed a decrease in visual analog scale for the dry needling plus the electrical nerve stimulation. For neck disability, there was no significant differences on the neck disability index that was found at 72 hours post-needling, so neck disability didn't change between the 2 groups. For pain pressure threshold, there was no statistical significant difference at baseline and at all follow-up periods. There was a between group difference that was found immediately post-dry needling, showing a higher improvement in the group that had electrical stimulation along with the needling. For cervical range of motion, there was no changes found at any of the follow-up periods for cervical range of motion. I think they only showed an improvement in one thing. So it was just 72 hours post-needling that there was an improvement in just extension and lateral flexion, but rotation didn't improve. So range of motion did actually improve, but not across the board, just in a couple of directions. So it was just lateral flexion and cervical extension. All right, for the discussion. So combining dry needling plus electrical nerve stimulation showed it significantly outperformed dry needling alone at reducing post-dry needling soreness in the first 72 hours after treatment. Also, after a single treatment of dry needling in the upper trap, neck pain intensity was decreased at 72 hours post-treatment, but not immediately after the treatment. However, when they applied the electrical nerve stimulation, neck pain intensity was decreased immediately post-treatment and at 72 hours post-treatment. So their neck pain intensity, if they had needling done without electrical stimulation, their neck pain intensity only improved at 72 hours after the technique. However, if they had electrical stimulation done along with needling, then they had improvements in neck pain intensity immediately after treatment and at 72 hours after the treatment. Both groups improved in disability regardless of whether or not they got electrical stimulation. For post-dry needling soreness, the group that had electrical stimulation had significantly greater reduction in post-dry needling soreness compared to dry needling alone. Neck pain intensity. Again, patients that had dry needling and electrical stimulation obtained greater improvements in neck pain than those that just had dry needling alone. No immediate decrease was found in just the dry needling group. But that group that had just dry needling did have improvements in neck pain intensity at 72 hours post-treatment. Now we're moving on to neck disability. Neck disability, it decreased significantly from baseline after the application of both groups, so whether it's dry needling alone or dry needling plus electrical stimulation. Pain pressure threshold, there was immediately an improvement in pain pressure threshold in the dry needling plus electrical nerve stimulation, but not the dry needling group alone, with between group differences being significantly in favor, obviously, of the electrical stimulation group. And then cervical range of motion. So although no statistical significant differences were found in our study, there were results that were better at 72 hours when the dry needling plus electrical stimulation was applied. It was only in extension and the lateral flexion. I'm just looking for where it says that. Yeah, there was an improvement in lateral flexion only with ischemic compression applied. You guys can look at the numbers also that were in that were in this table that's up here. It wasn't statistically significant, so you can take that for what it's worth. All right, and then looking at the limitations, one, they only put a needle in the upper trap. So they didn't actually needle the neck. They needled the schneck, right? The shoulder neck area, the upper trap. And it was only one needle. Although it's a common source of neck pain, additional needles probably would have been beneficial for both of these groups. But again, if you're applying more needles, you're just going to make them more sore. So that all comes into the dosage conversation. Secondly, there's no placebo group. Everybody got needled. And then third, electrical stimulation was applied for 15 minutes. However, doses greater than 20 minutes have been reported to produce an analgesic effect. Remember that for needling dosage, really between 10 and 30 minutes is ideal. So 15 minutes is still within that range, but 10 to 30 is really what you need. Any more than 30, there's no real benefit. Any less than 10, you're just not doing enough typically. As for their conclusion, the application of percutaneous electrical nerve stimulation after dry needling showed greater short-term improvements in post-dry needling soreness, neck pain, and mechanical hyperalgesia than dry needling alone, which leads to the conclusion that the combination of electrical stimulation and dry needling is more beneficial immediately following the treatment than applying dry needling alone in patients with neck pain. This is a really big deal because with our electrical stimulation, it is really a way to help improve their pain in the short term and in the long term. And you guys just saw that. But on top of that, if you can make them less sore, they're much more likely to let you try this again, especially at this 2 hertz frequency that they utilized in this study. It's a very, very comfortable frequency because it just feels like a tapping or a heartbeat. So this typically is very comfortable. I have patients fall asleep all the time with needles in them, but this is just more reason to be utilizing electrical stimulation with your patients. Now, I would argue that if you crank this up, if you just turned up the electrical stimulation as high as you possibly can, you're going to make them more sore. So you want this, and this is what they did in the study, you want it to be noticeable and decently strong, but tolerable. Your patient should never be struggling to relax while there are needles with electrical stimulation in them, because if you do crank it up, that will likely increase the dose. But if you have this at a comfortable level, you likely will help them with their pain both immediately after needling. You'll help them with their soreness immediately after needling, but also you'll even help them with their pain long term. And it's more likely that you will actually be able to keep this patient in the clinic, which means you'll do a better job of getting them the long-term results because you're able to initially get them those short-term results. If you guys have any questions on this, please reach out, post a comment, and we'll talk soon. Thank you.